Welcome to our video on pseudogout. Let's begin. Here's our overview slide. We will discuss definition, pathophysiology, clinical presentation, diagnosis, differential diagnosis, and management of pseudogout. Let's move on to the calcium pyrophosphate deposition disease, that is pseudogout. Calcium pyrophosphate deposition disease is an inflammatory crystal-induced arthritis due to deposition of calcium pyrophosphate dihydrate crystals in the joints. It is common in people over 50 years of age. Let's talk about the pathophysiology of calcium pyrophosphate deposition disease. It is mostly idiopathic. However, joint trauma due to any reason can predispose to calcification of the articular cartilage. Joint trauma can be associated with the joint surgery, osteoarthritis, or previous juvenile idiopathic arthritis. Hypercalcemia causes calcium deposition in the articular cartilage. Hyperparathyroidism, mild hypomagnesemia, and Gitelman disease can all result in calcium pyrophosphate deposition disease because all of these conditions are characterized by hypercalcemia. Hyperphosphatemia can also induce pseudogout because phosphate drives calcium into the tissues, including cartilage. Finally, hemochromatosis is associated with calcium pyrophosphate deposition disease due to increased serum pyrophosphate levels. Acute calcium pyrophosphate deposition disease is also known as pseudogout because it mimics gout. Pseudogout is the acute monoarthritis most commonly manifested in the knee or the wrist. It is characterized by pain, warmth, erythema, and swelling of the joint. Signs of systemic inflammation like fever and chills are also common. The acute attack of calcium pyrophosphate deposition disease usually lasts longer than that of gout. Other potential joints affected by this disease include ankles, hips, and interphalangeal joints. Let's move on to the chronic calcium pyrophosphate deposition disease. Chronic form of this disease is also known as pseudo-osteoarthritis because it mimics osteoarthritis. Chronic CPPD is characterized by polyarticular pain due to progressive joint degeneration. It's typically more severe than osteoarthritis, but chronic CPPD can coexist with osteoarthritis. This condition is also characterized by asymmetric joint involvement and the short-term morning stiffness. Let's talk about the diagnosis of calcium pyrophosphate deposition disease. Arthrocentesis with synovial fluid analysis is the gold standard for diagnosis. Polarized light microscopy is commonly used to visualize calcium pyrophosphate crystals. These are weakly positively birefringent rhomboid-shaped crystals. In other words, if the crystal is parallel to the polarized light, it appears blue. If it is perpendicular to the light, it appears yellow. Additionally, synovial fluid white blood cell count is usually from 2,000 to 50,000 cells, suggesting non-infectious inflammation. Finally, synovial fluid gram stain is negative, favoring the diagnosis of pseudogout over septic arthritis. This is the polarized microscopy image showing calcium pyrophosphate crystals. Please look at where the white arrow points and take notice that these are weakly positive birefringent rhomboid-shaped crystals. This is in contrast to negatively birefringent needle-shaped monosodium urate crystals seen in gout. A 49-year-old woman comes to the physician with severe right knee pain. She has past medical history of untreated primary hyperparathyroidism. The physical exam reveals swollen and erythematous right knee. Arthrocentesis, followed by synovial fluid analysis, shows negative gram stain and white blood cell count of 10,000 cells. Her serum calcium is 12. What would most likely be seen under polarized light microscopy? This patient with untreated primary hyperparathyroidism and hypercalcemia presents with swollen, painful, and erythematous right knee. The synovial fluid white blood cell count indicates inflammatory non-infectious arthritis. Considering her comorbidity, she likely suffers from acute calcium pyrophosphate deposition disease, also known as pseudogout. Polarized light microscopy typically shows weakly birefringent rhomboid-shaped crystals in the patients with pseudogout. Moving on, let's discuss what the imaging studies show in CPPD. X-ray usually shows chondrocalcinosis. Chondrocalcinosis is manifested by the opaque lines within the cartilage due to calcification. Ultrasound also shows hyperechoic deposits in the cartilage consistent with calcium pyrophosphate crystals. CT and MRI are rarely performed for calcium pyrophosphate deposition disease. This is an X-ray of the knee showing transverse opaque lines within the articular cartilage. These lines are consistent with the calcium pyrophosphate deposits. Here you see a graphical representation of the hyperechoic deposits in calcium pyrophosphate deposition disease. Please note that these deposits are within the articular cartilage. They are consistent with calcium pyrophosphate disease. Since calcium pyrophosphate deposition disease can be secondarily caused by other diseases, we should evaluate the patients for underlying disorders. Serum ferritin should be measured to check for hemochromatosis. Serum calcium and magnesium are checked to evaluate for possible hypercalcemia and hypomagnesemia, respectively. Since hyperphosphatemia is also associated with pseudogout, serum phosphate levels should be measured. Finally, measurement of parathyroid hormone and alkaline phosphatase levels may indicate the presence of primary hyperparathyroidism. As you can see, the differential diagnosis of the pseudogout involves the same diseases that we already discussed while talking about gout. They include septic arthritis, gout, rheumatoid arthritis, erosive osteoarthritis, and seronegative spondyloarthritis, such as reactive arthritis and psoriatic arthritis. It's important to watch out for the characteristic signs and symptoms of these conditions that we discussed when we talked about the differential diagnosis of gout. The management of acute calcium pyrophosphate deposition disease is the same as that of acute gout attack. NSAIDs, especially naproxen or indomethacin, are preferred as the first-line agents unless the patient has chronic kidney disease or peptic ulcer disease. NSAIDs will exacerbate both of these conditions. Colchicine is an alternative to NSAIDs. However, it is contraindicated in liver failure and chronic kidney disease due to its hepatic metabolism and renal excretion. Corticosteroids such as prednisone can be administered orally, intravenously, or via intra-articular route. Corticosteroids are used when the patient has a contraindication or resistance to NSAIDs and colchicine. For example, we will avoid both NSAIDs and colchicine in chronic kidney disease due to their nephrotoxicity, and then we will administer corticosteroids. It's worth noting that systemic formulations of corticosteroids are avoided in patients with diabetes mellitus because steroids can further increase the blood glucose levels. Chronic calcium pyrophosphate deposition disease is treated with low-dose colchicine for prophylaxis against the acute attacks. We should also treat any underlying conditions such as hyperparathyroidism or hemochromatosis. Here we have the table summarizing similarities and key differences between gout and calcium pyrophosphate deposition disease. Please pause the video and take a moment to consider this table. A 52-year-old man comes to the physician reporting left knee pain for the last day. His past medical history is significant for hereditary hemochromatosis, treated with phlebotomy. He missed the last 2 phlebotomy sessions. His vital signs include a temperature of 36 degrees Celsius, a blood pressure of 135/80, and heart rate of 84, and a respiratory rate of 15. The physical exam reveals an erythematous, swollen, and tender left knee. Arthrocentesis, followed by synovial fluid analysis, shows white blood cell count of 30,000, negative gram stain, and positively birefringent rhomboid-shaped crystals under the polarized light microscopy. His serum creatinine and blood urea nitrogen levels are normal. Which of the following is the best treatment for this patient's acute condition? A. Indomethacin, B. Colchicine, C. Oral corticosteroids, or D. IV corticosteroids. This patient with a past medical history of hereditary hemochromatosis presents with erythematous, swollen, and tender left knee. He missed the last 2 phlebotomy sessions, predisposing him to pyrophosphate accumulation. Pyrophosphate, in turn, can induce calcium pyrophosphate deposition in the joints, causing pseudogout. Pseudogout is confirmed by positively birefringent rhomboid crystals under the polarized light microscopy. Additionally, negative gram stain and the white blood cell count of 30,000 in the synovial fluid indicate inflammatory rather than infectious etiology. Considering that his creatinine and blood urea nitrogen levels are normal, and he has no history of peptic ulcer disease, the first-line treatment option for pseudogout is a non-steroidal anti-inflammatory drug. Indomethacin is an NSAID, so the correct answer is A. Here is the slide reminding us of the management of an acute calcium pyrophosphate deposition disease. Let's discuss why the other options are incorrect. Option B, colchicine, is incorrect because although it can be used in chronic as well as acute CPPD, it is not the first-line medication for an acute condition. Options C and D, oral and IV corticosteroids, are incorrect because they are used in acute CPPD if the patient has a contraindication for NSAID. And that concludes our lecture on pseudogout.